Good morning. If everyone would take a seat, please. I love this sound. This is the sound of everyone connecting in the room. But we do want to get started this morning. So if everyone could take a seat. I'll go ahead and get started. Good morning. I'm Maureen Mahoney. I'm Mayor Holland's Chief of Staff here at the Unified Government in Wyandotte County in Kansas City, Kansas. It's wonderful to see this room full of so many people committed to health and growth in Wyandotte County. Mayor Holland regrets having to miss this. He got called out of town unexpectedly yesterday, or he would be giving this address. So again, welcome to our city and to the Reardon Center, and we thank all of those in our staff. I am one of the 15 Sunflower Foundation Fellows for this year, so the Sunflower Foundation is the group that's hosting this, and Ms. Hall will be up to tell you more about the foundation and introduce our speaker. I don't want to let this opportunity go by without talking about the county health rankings that came out yesterday officially. I know that this is an educated group, so you do understand. These are for Wyandotte County, which again, if you don't know, came in last in the state in all the counties, and Johnson County came in first. So it's a pretty easy tie beyond just thinking about access to a doctor or your health in that respect. It is a much broader conversation. Commissioner Brian McKiernan is one of the Unified Government Commissioners. He also has his PhD, and he's now retired, so he loves to work with numbers. So he has gone through and looked at all the metrics that drive where you end up on the list. And he has found this fascinating look. If you weigh it appropriately and weigh these factors, every year the top 3 reasons why Wyandotte County ranks last are the number of children in poverty, unemployment, and adult smoking. And so he said, I wanted to test my theory, so he went to other states and looked at the county that was ranked last. And in each of those counties, it's the same 2 factors, number of children in poverty and unemployment. So we know intuitively that social determinants affect one's health, but now we know by the numbers. So the other thing I want to tell you, that this came out in 2009 when then Joe Reardon was mayor, and he decided, I'm not going to shoot the messenger. I'm going to look at these numbers and decide how can we fix this. So he, with the help of Mayor Holland, who was then a commissioner, and several others, created Healthy Communities Wyandotte. And there are a number of areas that we focused in: access to healthy food, access to healthy infrastructure, access to health care, communication and education, and we've also added smoking cessation as another policy. So this has been in place since 2009. And let me tell you some of the successes that we've had very quickly that don't yet register on the county rankings. So Wyandotte County, 10% of the population of the state of 5%, pardon me, I'm saying this wrong. 5% of the state population, 10% of the state's uninsured. Because we had this Healthy Communities Wyandotte structure, when the Affordable Care Act rollout occurred, we had all of our community partners, a number of whom are here in this room, helped us cut our number of people unemployed in Wyandotte County from 26% to 18%. So that's a third of our population who now have health insurance. But that doesn't show up on our rankings. So I just want to tell you there are a lot of good things happening that we will continue to roll out to you and let you know as we continue to bring these numbers down. So again, thank you for coming. Thanks for coming to our city. And I am going to introduce Billy Hall, who is the Executive Director of the Sunflower Foundation. Thanks.
Well, thank you, Maureen, and I appreciate the introduction and also the chance to reflect about the issue that we're here to talk to, or to have a conversation about today. Some of the biggest challenges that we all face in working to improve the health of our residents in Kansas and in the Kansas City area, of course, in the metro area as well. The toughest challenges, health inequities that cross all the areas that we work in. And the Sunflower Foundation, who is here today as part of an advocacy fellowship initiative that we have, we've brought in someone that I think will speak to us and help us learn even more about how we can address such tough issues. So just a couple things. First, happy St. Patrick's Day. That's kind of an interesting time to be meeting. And a couple notes about the Sunflower Foundation. We're a statewide health foundation. We serve all the counties in Kansas. Our mission is to serve as a catalyst to improve the health of Kansans. The key word there is catalyst because we can't do it all, nor would we even think we could. We have the good fortune in Kansas to have 6 health conversion foundations that work in our state. That is amazing for the size of Kansas, and so I'm very grateful to be part of a very rich and innovative health philanthropy community. I want to just mention again our fellowship program. You probably picked up some information about it. It's a biannual program. This year, it's structured differently than we've done in years in the past. We've put together a diverse group of fellows that represent the key components or pillars of a community. So this is different for us. We've been doing this fellowship program now for about 8 years, and we focused on health leaders and health and social service leaders, which we will continue to do. But this time we brought in business, faith, education, government, and that is really the way in which we're going to make a difference. We have to work across sector. And this has been an exciting class, and if you want more information about the fellowship, you can go to our website. What we're doing this time, which is a little different, I want to introduce Chris Whitman over here on my left. She is an artist who's going to be illustrating and capturing the conversation, both the speakers' comments and the interaction that we'll have with you today. Chris has done this once before for Sunflower Foundation. It's fascinating. So after our presentation, be sure to come by and take a look at her drawings, her pictures. There were some questions, and I see some of you answered those. Those are kind of fun, so if you haven't done that, do that before you leave. So I want to get right to the introduction because I want to leave more time for our guest, our keynote speaker, and for you in terms of any questions you might have. So I've had the opportunity to know Dr. Tony Iton for almost 6 years or so. We both we're part of the health philanthropy community across the country. He is the Senior Vice President for Healthy Communities at the California Endowment, a very significant foundation. I think the California Endowment is about the same age as the Sunflower Foundation, somewhere in the 15-year, maybe a little older or so. A lot of conversion. We came from a Blue Cross Blue Shield quasi-conversion, and so there are a number of foundations that I have the opportunity to connect with through Grant Makers in Health, which is a national association that we all work and contribute to. And I have been fascinated with this topic for a long time. I'm a public health educator, like a lot of you. When I went to school, we were talking about healthy behaviors and individual motivation and all those things. And most of us knew, though, that there were other factors present. And, it's a journey as you begin to realize that it's much broader than some of the basic learning and teaching that I had in the beginning. And the challenges today around a number of issues, the social determinants of health and the challenges we have in health equity and the programs that we are working on. So that's what we're here for today. Dr. Iton is a physician. He also holds a JD and a Master of Public Health. He's had a career in public health, Director and Health Officer of the Alameda County Health Department. He was an HIV disability rights attorney at Berkeley Community Law Center and a health policy analyst with Consumers Union. You've covered a lot of sectors in that. And also just a longtime physician and advocate for the homeless in his career at the San Francisco Public Health Department. So I'm not going to say any more. He's here to talk about a very challenging issue. And with that, I'd like to welcome Dr. Tony Iton.
Well, good morning. I don't know very much about Kansas, but what I do know is that you're notoriously polite. And so I'm going to take advantage of that and encourage you to ask questions. This is much more fun for me when it's interactive, and it's, I think, a better learning experience. And so some of these slides, actually towards the beginning, are going to prompt a little bit of interactivity. So prove to me that Kansans are polite and engaged and interested, which I believe. I was telling Billy yesterday that my primary experience with Kansas is on I-70, and I feel really good to be firmly planted on the ground in Kansas, meeting Kansans. I learn through interactions. I'm a very kind of interactive person. And so just the questions, the comments, the challenges are really, really helpful to me. So selfishly, I really want you to talk to me. I want to thank Billy and just talk about her just for a brief moment. She's on the board of Grant Makers in Health, as she mentioned, and I want to tell you how well she represents Kansas in that space. You can imagine, I think, that the country has these big foundations on the coasts that have a ton of money, relatively speaking, and kind of these very authoritative kind of postures. And sometimes the middle of the country, the South, doesn't get as well represented when we're talking about the challenges facing the country. Not at GIH, thanks to Billy and some of her colleagues. I know more about Kansas from Billy than I know about any other state in the country. And and first of all, Kansas has got a colorful story when it comes to health. I mean, you've got Kathleen Sebelius, you've got your governor. I mean, you've got some, just some really interesting characters that have played, kind of a key role in the rollout of health reform and the like. So, but Billy reminds us every day that, not every place is California or New York, and the challenges of advancing things like health equity in Kansas are fraught with some interesting, twists and turns. So I just want to appreciate her for her leadership. She's coming off the board. She just had her last board meeting, and we're going to miss her dearly. Maybe able to give her a little hand for that. Okay, so slides, I guess. Wait, I have the slide thing, so I'm in control. All right, so I want to tell you a story. I want to tell you a story about me and sort of how I got into this work. And so I'm going to first talk you through a little bit of my life. But before I do that, I want to show you a quote. This is the quote, and I'm going to try to read it out to you from here. Hopefully I can do that. And then I want you to tell me who said it. And if you know already who said it, don't shout it out. I want people who don't know who said it to guess who said it. I will say then that I am not, nor have ever been, in favor of bringing about in any way the social and political equality of the white and black races. That I am not, nor ever have been, in favor of making voters or jurors of Negroes, nor of qualifying them to hold office, nor to intermarry with white people. And I will say in addition to this, that there is a physical difference between the white and black races, which I believe will forever forbid the two races living together on terms of social and political equality. And inasmuch as they cannot so live, while they do remain together, there must be the position of superior and inferior. And I, as much as any other man, am in favor of having the superior position assigned to the white race. All right, who thinks they know who said that? George Wallace. Yeah, that's a quote I've often heard. At least that's a suggestion I've often heard. It is not George Wallace. It precedes George Wallace. Yes? Thomas Jefferson. That's also a suggestion that I've heard. It's not Thomas Jefferson. This is a person who actually was a president of the United States, but came after Thomas Jefferson. Sorry, what was that? Abraham Lincoln. Now, why do you say Abraham Lincoln? Okay, so I don't know if you heard that, but that's exactly right. This was Abraham Lincoln during the Lincoln-Douglas debates in 1858. And what I'd like to know, now I told you Kansans are polite, but I'm hoping Kansans are also honest. How many of you are surprised by this? Raise your hand. Thank you. You are honest people. How many of you are not surprised by this? Okay. I want 2 people who are not surprised to tell me why they are not surprised. Yes?
History buff, I read a lot of biography.
Okay, so tell me what he was saying here. Is Abraham Lincoln a racist?
Well, actually his goal ultimately was not just to separate and bring the black race out of slavery, but he wanted to send them offshore as well. He did not want them left here in this country. So he definitely wanted to send them back to where they came from.
Okay, so have you been to the Lincoln Memorial? Yes. Now, is this carved into granite at the Lincoln Memorial? Because there's a lot of his speeches carved into, granite or marble or whatever it is. And I'm curious as to why this one is not up there. All right, somebody else. Thank you.
Yes, sir, I'll stand and respect the audience. I am not a history buff. Everything about history surprises me. But when I learned that Abraham Lincoln was not really trying to do what history says he was trying to do, then I began to follow it. This does not surprise me, and it does not surprise me that it's not engraved on anything, because we are a nation that avoids honest, open conversations about stuff that impacts us.
Okay, thank you very much. Okay, so Abraham Lincoln is known as the great emancipator, right? And one of our, great leaders. Obviously, we have him up on the Capitol Mall, and we, millions of people go up and traipse up there, and school children read about how great Lincoln was. And the reason I show you this quote, it surprised me, by the way, when I found it, is that I want to give you a sense of the power of narrative, a story that we tell ourselves about who we are and about why we're here, and how that narrative shapes everything. That narrative shapes policy. That policy creates conditions. Those conditions create risk for people who are trying to pursue health. And we spend a lot of time, and I'm going to show you a framework a little bit later, we spend a lot of time trying to solve the symptoms of those conditions that are created by policy that are shaped by narrative. And this narrative, by the way, Lincoln's narrative, is not the only narrative in this country. There's a competing narrative, which is really more one of equality, one of opportunity, one of meritocracy. And these 2 narratives have competed since the beginning, even before the beginning of this country, and they continue to compete today. You only have to watch the Republican and Democratic presidential primaries to see those 2 narratives competing against each other. But we'll get back to that. Okay, so I want to tell you a little bit about me now and place. This is the place that I grew up. It's a beautiful city. It's an island which is an old volcano. It sits in the middle of a river. with a beautiful park on the top of the volcano. And it was a wonderful place for me to grow up. Does anybody have any clue where this is? I'm hearing murmurings. Okay, let me give you a few more hints. It is not in this country. England, the Philippines, no, no. Say again? Caribbean, no, although my parents did, so that's not a bad guess. It is a cold place. Yes, who said that? Quebec, yes. Any particular place in Quebec? City? Not Quebec City, although it's close to Quebec City. Let me give you a few more hints. Uh-oh, did I lose control here? Oh, there we go. A lot of outdoor cafes. It's got a French-English culture. Say again? Montreal? Yes, there's that Kansas spirit. Montreal. Montreal, Canada. And I grew up in the 1960s and the 70s and 80s in Montreal. I think I've lost control of this thing. Do I point it somewhere that I'm not pointing it at? There we go. This is a view of Montreal, downtown Montreal in the background there, the St. Lawrence River. You can see behind the city there, and in the foreground is McGill University, where I went to school for free. Montreal hosted the 1976 Olympic Games, the 1967 World's Fair. At one point, it was one of the wealthiest cities in North America, no longer the case. But it was a wonderful place to grow up, and I'll tell you why, if this thing will allow me to. That's my brother and I in Montreal as kids. Canada has a strong social contract with its citizens. There's universal health insurance called Medicare, the Canadian Health Act. There's universal dental care up until the age of 10. There's universal child care benefits for all Canadians. There's highly subsidized post-secondary education. As I said, I went to McGill University, a renowned international university, for free. As a matter of fact, they paid me to go there because I got a scholarship that paid more than my tuition. Very high quality community resources, parks, sports leagues, libraries, community centers. In fact, when I go back up there with my kids these days and hang out, I get the sense that the resources that are available to everybody in pretty much any city, and I've looked all throughout Canada to find the place that doesn't have this, and I haven't been able to find it. You find resources of the quality that you would expect to find at a country club here in the US, where you'd have to pay a membership and an annual subscription fee or whatever. In Canada, you can find these resources that are widely available to the whole populace. Canada invested in me.
Dr. Iton?
Yes.
I do have a question.
Yes,
Do
please.
you feel that it has the same social contract with its Aboriginal residents?
I think Canada has a problem with the Aboriginal relations, and to the extent, and I'm going to get into this a little bit, to the extent that Canada has a blind spot, it's with the Aboriginal residents. Although, if you compare the status of Aborigines or Native Canadians in Canada to the status of Native Americans here, you see some real parallels, and shocking parallels. Okay, let me keep going. So in 1985, I went from Montreal to Baltimore, Maryland, because I got into Johns Hopkins Medical School, where I was told this was the best medical school in the world, and at Hopkins, in fact, they tell you that we may not be the best, but there's nobody better. So I was delighted. This is, the citadel of health in North America. But this is what I confronted when I got to Johns Hopkins. And these are scenes from immediately adjacent to Johns Hopkins Hospital in East Baltimore. And I, for the life of me, had no idea what I was seeing. Being this young Canadian kid, although I was born in the US by accident, I grew up in Canada. And so I came to see this, and this was in the mid-'80s, and I said to the person who was showing me around East Baltimore, I literally said to him, I said, when was there a war here? And I'll never forget what he said to me. He looked at me with this total look of disdain, and he said, what'd you expect? It's the inner city. And I thought, what do I expect? I should expect this? This is a norm. This is a way that we expect people to live. And we've named it. We call it the inner city. And from that day on, I've been trying to explain this and its impact on health to myself. That's the story of my career. And I wonder, who would I have been had I grown up in East Baltimore? That kid, for all intents and purposes, is me. And what is the social contract that this kid is experiencing? This kid did not create those conditions, yet is expected to find health and opportunity in that environment through no fault of his own. And that, to me, is essentially what health equity is about. How is this equitable? What opportunities are we really creating for a young child like this? Okay, so I go back to Hopkins periodically to talk about the social determinants of health, and I take pictures. I bring my camera. This is from the same neighborhood 2 years ago. And of course, we know what happened in Baltimore not too long ago. And for those of us who spent a little bit of time in Baltimore in our lives, this was not at all unexpected. I mean, this is essentially Baltimore being a smoldering riot for 50 years. In fact, Time magazine asked that question directly. Okay, now here's the part where I throw you a little curveball. Because this is a place that's very much like Kansas. This is Scott County, Indiana. Does anybody know what Scott County, Indiana has become a little notorious for recently? Yes?
HIV epidemic from IV drugs.
Yes. And why is that interesting?
Because this is a very rural town that has never seen anything like this, but it's very high in poverty and very high in minorities, and pretty much because it's forgotten about. So when they had opiates being prescribed at high levels there, and then that was shut down. Hello. Sorry, y'all. So Scott County is very rural in Indiana and has very high levels of poverty, and there were people prescribing high levels of opiates to the residents there, and when that was shut down, the residents turned to heroin, and unfortunately that has caused a high percentage of the residents to have HIV, Hep C. CDC's been into it. They've started needle exchange programs. It's been a very big issue for Indiana.
Yeah, perfect. Before you give the microphone away, what did you say about the demographics? High population of what?
Of poverty, I think over 30% of their population is living below the federal poverty line. I think it's very rural, and I think they have a high level of minority as well.
Why would you
don't know
think
about that for sure.
What? Yeah. Why would you think that?
Because unfortunately, we automatically assign poverty to minorities.
Yes, we do. Unfortunately, that is not the case here. In Scott County, Indiana, it's 98% white. And what I'm arguing here is that, and thank you for that, by the way, that was a beautiful description of my slides. What I'm arguing here is that when you look at East Baltimore and you look at Scott County, Indiana, you're looking at the same phenomenon. You're looking at income equality in black and white and trying to understand what the root causes of the hopelessness that drives these behavioral manifestations is what health equity is about. And it is not just black people. But we'll talk a little bit more about that. So the question for me became, in this journey, does your zip code matter more than your genetic code when it comes to your health? And I'm going to present you the data that suggests that this is in fact the case. Okay, so after medical school, I ended up doing some things and ultimately ended up in the San Francisco Bay Area. For those of you who don't know what that looks like, there's California, there's the Bay Area. This is a zoomed-in version of that. That's San Francisco there. And I became the health director and health officer of Alameda County, which is shaped like a big boot that's trying to crush San Francisco, which we often fantasized about. And the interesting part of this map, the reason I show you a map is I'm going to show you a bunch of other maps of this boot shape. And then in the foot part of the boot is the older part of the county, which is Berkeley and Oakland. And going down towards the heel, there's a 1970s era set of suburbs that pursues a freeway going down in that direction. Across the bay there is Silicon Valley, where Google and Apple and a whole bunch of big high-tech firms are. And then going up in the laces you've got kind of a 1980s era suburbs. And the back part of the boot is really kind of rural, although you've got 2 nuclear bomb making labs there, Sandia National Labs and Lawrence Livermore National Labs, and then a heck of a lot of goat farms. So one of the first tasks I had was to figure out why there was plutonium accumulating in goat manure piles in rural Alameda County. That's a true story. That was my first public health job. The other thing that you get to do when you're the public health officer is that you're the guardian of all births and deaths. You're literally the registrar of birth and death, which sounds boring, but I found this fascinating. It was just so much fun because it's a perfect database. There are about 10,000 deaths every year in Alameda County, about 20,000 births. And you couldn't actually, I used to tell people, you're not dead until I say you're dead in Alameda County, because I literally had to sign the death certificate. And so you could actually control the data on the death certificate. If people weren't filling out items on the death certificate, you could say, not signing it until you give us the data. So it's actually a fairly good source of data. And we compiled a database of about 500,000 death certificates in Alameda County. And on a death certificate, you can find out what somebody died of, what their age was when they died, what their race, ethnicity was, and where they lived. And those 4 pieces of data on a death certificate can give you a really interesting profile about patterns of death in a community. Okay, the first thing that we did with this database, and I'll tell you, interestingly enough, whenever I come to a place to talk about this stuff, I always want to see their death data, which makes me sound kind of morbid or whatever. But I'm like, do you have data on death? And so I'm going to show you a little bit of Kansas data that I found. But when I started my job as the health director, I literally didn't know what my job was. I had no idea what I was supposed to do. So I looked at Healthy People 2000 at the time, and Healthy People 2000 said the number 1 goal was to increase life expectancy for all Americans. And the number 2 goal was to eliminate health disparities amongst various different groups of Americans. So I said, okay, this must be my job for Alameda County. So I went to my well-trained epidemiologist and I said, what is life expectancy in Alameda County? And they said to me, I don't know. And I said, well, it's the number 1 goal of Healthy People 2000. They're like, well, we've got a whole bunch of death certificates, we can measure it. And I said, yeah, let's do that. I went around the San Francisco Bay Area, talked to health officers, and I said, what's life expectancy in your jurisdiction? They said, I don't know. And so we started measuring it. And when we started measuring it, we found some very interesting things. So the first thing we found is that you can go back in time. We could go back in time in Alameda County's data set to the mid-1950s. When you do that, to calculate life expectancy, you need deaths in the numerator and the population in the denominator. But because the census didn't really start talking about any other racial groups other than white and black until 1990, if you want to go back before 1990 and talk about other groups, you can't. You can only talk about white, black, and other. So this is white and black from 1960 to 2005. And we found that in 1960, the life expectancy difference between whites and blacks in Alameda County was about 2 years, 2.3 years. 20 years later, it had more than doubled to approaching 5 years. And then 45 years later, it had almost quadrupled to approaching 8 years. And this is during a time, mind you, of revolutions in health care. You're talking about minimally invasive surgery, CAT scans, MRIs, pharmaceutical wonder drugs. And what we see during this time is the life expectancy of both those populations is increasing, but the gap between those two is increasing dramatically. And so we tried to analyze this, and we asked our epidemiologists, what is this? Is this some rare disease? And they said, well, it may be HIV. It may be homicide. So we subtracted out homicide, we subtracted out HIV, and we found that those 2 diseases contributed relatively little to this life expectancy difference. This difference is driven by chronic disease. Heart disease, cancer, stroke, bread and butter things that we ostensibly know how to treat and prevent. And that was good information for us, that this disparity is being driven by chronic disease. The other thing you can do with a death certificate, which is what I enjoy doing, is taking the boot, Alameda County, and mapping it. Now, for every census tract, there are about 150 of them in Alameda County. And you can do this in Kansas, and I'm going to show you some data at the county level. This is sub-county. This is like 150 neighborhoods in the county of Alameda, we can calculate the average age to which somebody can expect to live in that neighborhood. And so what we did, and the color on this has kind of gone a little funny, but the upper box there are green, greater than 80 years. On average, the people living in those communities can expect to live greater than 80 years. And the red, which is the lower box, is less than 74 years. And that's on average. And the yellow is between 74 and 80 years. Now, when I first started showing this, we published this map in a report. It ended up on the front page of the San Francisco Chronicle and the Oakland Tribune, and it caused a big stir. People were really kind of shocked by this. People started saying to me, which I thought was really funny, boy, I don't want to live in Alameda County. Sounds like a really inequitable place. And I thought, really? Is that the message you take from this map? So we had to start taking this analysis to other places. So this is Cuyahoga County, Cleveland, which shows enormous gaps in life expectancy, almost approaching 30 years. This is Baltimore, Maryland. I had to go back to Baltimore, and there are neighborhoods in Baltimore with life expectancies in the 50s, average life expectancy in the 50s. This is Los Angeles, which showed similar big gaps. This is Seattle, King County. This is New York City. This is Philadelphia. This is Minneapolis, St. Paul. This is Boston. Everywhere we have looked, we have found gaps on the order of 15 to 25 years. And some places more than 25 years. And so we've never looked anywhere where we've not found these gaps. And I'd love to find a place where we don't find this. I would want to move to that place. We have not been able to find that. This is the state of California, every census tract in the state of California, where we see a life expectancy gap on the order of about 20 years across the state. This is something that the Robert Wood Johnson Foundation did just next door in Kansas City, Missouri, predicting life expectancy based on what exit you take on the freeway. So imagine instead of like Main Street, it just said your life expectancy. Exit here. I tried to find as much data as I could about Kansas City, Kansas. I found quite a bit about Kansas City, Missouri. And so this is Kansas City, Missouri, looking at life expectancies stratified across the city down to zip codes and smaller geographic areas, which I think is important. When you look at this data, you've got to understand that there are big differences just between neighborhoods. And trying to understand those differences and help people in those neighborhoods understand those differences is really critical. When you look at the whole county, you're essentially averaging out a whole bunch of lows and a whole bunch of highs, and you're hiding, some very important data. This is what I found for Kansas, the state of Kansas, and Wyandotte County is that sort of circled yellow box there, which you probably know better than I do. And of course, we have this recent Robert Wood Johnson health rankings data, which is, I don't know if you could find anything more kind of glaring. This is Johnson County, which is number 1 in 2016. And then this is Wyandotte County, number 101 in 2016. So you've got both ends of the spectrum right next to each other. And we have to try to understand this in order to understand how to approach health equity. Okay, so the other thing you can do, again, this is the boot. This is Alameda County. The upper map there is life expectancy at every neighborhood in Alameda County, and the bottom one is household income, or percentage of people living in poverty in those same neighborhoods. And you can do a simple correlation. For every census tract, you have a life expectancy and you have an income, so you can correlate those on a graph. It's called a bivariate correlation. This is life expectancy from low to high. And this is poverty from low poverty, in other words, wealthy communities, to poor communities. And each of these blue dots is a neighborhood in Alameda County. And you see this kind of clustering of blue dots that are relatively wealthy, relatively high life expectancy. And then as you move across the income gradient, you see this sort of downward trajectory. And in an ideal world, this would be a completely flat line. Where you live shouldn't predict how long you live. But we don't live in an ideal world. There's a cost to living in a low-income community in America, and it's a tax. It's a tax on length of life. You pay a heavier tax, a death tax, for living in a low-income community. And that's what these communities are experiencing. So not only did we do this in Alameda County, we did this for the entire San Francisco Bay Area. We did it for the entire state of California. Now, you can't put this on the front page of the newspaper because nobody knows what this is without a long explanation, but you can translate it, which is what we did. We just took the slope of the line in the Bay Area, and we told people that every additional $12,500 in household income buys you a year of life in the San Francisco Bay Area. That's the cost of life. That's what we're worth. By the way, if you want a real deal on life, you can get 3 years for $10,000 in Baltimore. So if you're looking for a deal. Some of you, I don't know how many of you might be data nerds like me, that were looking at this data and thinking, usually when I do this to a lot of physicians and public health folks, and by this point of the presentation, people are starting to get visibly agitated. And that is because data nerds realize that everything that I showed you up until this point is a correlation. It's an association between one variable and another variable, which does not prove cause and effect. Two things can be associated with each other, but they're not causing each other. In order to prove cause and effect, you'd have to do a radical experiment. You'd have to take this room, divide it in half, expose half of you to extremely harsh environmental circumstances for 30 to 40 years, and the other half of you we'd have to leave to sort of relatively normal, benign circumstances. And then we'd have to look at how long each of you lived and compare the two of you. Then we'd be able to prove that the environment caused premature mortality. Well, we obviously can't do that, but in Alameda County, we have the next best thing. We have a longitudinal cohort study that's still ongoing. It's been going since 1965, and it's 7,000 Alameda County residents that have been followed since the 1960s. And this cohort has led to the publication of about 200 papers. Amongst one of those papers is the one that shows that if your household income is 1 standard deviation above the mean, you're 25% less likely to die prematurely. If you're 1 standard deviation below the mean, you're 35% more likely to die prematurely, which is almost an exact fit with that so-called regression line on that previous graphic that I showed you. So we have confirmation that this is cause and effect. And again, it's not unique to Alameda County. We just happen to have some very good data. So some of you have seen this data. You probably all have seen this data at one point, or heard about it, read about it. Don't try to read it. It's basically all of the developed countries in the world, the so-called OECD countries, and their per capita spending on healthcare. And of course, when you do this graphic, you always have to change the axis to fit the United States on it, because we're such big spenders on healthcare. We love our healthcare, and we spend a lot. That's not that interesting, although you'll note that for what we spend, you would expect our life expectancy would be a lot better. It is not. It should be up here. Actually, it should be close over here. It's in fact down here, compared to all these other countries that spend a lot less but get a lot more. Well, there's a woman by the name of Elizabeth Bradley and another woman by the name of Lauren Taylor who did something very interesting that ended up being just an op-ed in the New York Times. And they decided, rather than just looking at healthcare spending, that they would combine healthcare spending and social services spending in the OECD countries on a per capita basis. In other words, on average, per person, how much do you spend on healthcare, how much do you spend on social services? And when you do that, all of a sudden the United States is not the outlier. We're sort of smack dab in the middle of the pack. That blue is our healthcare spending, and this red is our per capita social services spending. And what they found is this really interesting relationship that the more you spend on social services compared to healthcare, the better your health was. So we've got the accent on the wrong syllable. We're literally spending downstream instead of upstream, when the rest of the world has proven that spending upstream actually is better for your health. And so their conclusion was it's the ratio of social services spending to health spending that actually correlates best with health outcomes. And important health outcomes like infant mortality, low birth weight, premature death, longer life expectancy, these are the things that we're paying a lot of money for trying to remedy in hospitals. This is another interesting study, and I'm going to go through this fairly quickly because there's a lot of dots, and I'm not sure you can see them all. But these are the same countries, and again, looking at per capita spending, national income per person in general. And this is life expectancy. So, presumably the richer countries, like the United States, are further out on this part of the spectrum. But the countries that do best in terms of health are higher up on this spectrum. So here's Japan, Switzerland, and some other countries. And they thought that there would be a relationship between how much money you have on a per capita basis and how healthy you were. And they found that that is not the case. There is no significant trend line here. It kind of goes up, goes down, goes in the middle. So they resorted the bottom axis. Instead of looking at per capita income, they looked at income inequality, how that money is distributed within the society. And what they found now is all of a sudden they have a relationship. That those countries that are most unequal in their spending have the lowest life expectancies. And the ones that are most equal have the highest life expectancy. There's a relationship between income inequality and life expectancy. They took this one step further. They took all of the 50 United States, or all the 50 states in the United States. They created an index of health and social problems. So a high level of this is bad, low is good. And they looked at per capita income, and they found basically no relationship. But then they resorted, looking at income inequality in the states, and all of a sudden they had a relationship. So low income inequality, and here's places like Utah, New Hampshire. See if I can find Kansas. Anybody see Kansas there? Okay, I can't see it, so. I'm almost there? Which way, right or left? Left. Oh, there's Kansas. Okay, thank you. So almost on the line, actually, sort of low, relatively low income inequality, relatively low index of health and social problems. Now those with very high income inequality, Mississippi, Louisiana, Alabama, have the worst index of health and social problems and the highest level of income inequality. Now the clue here is that it's not how much money we have, it's how we use that money, how we invest that money, what kind of opportunity structures exist for everybody. That's the clue. This is not proof. Again, this is an association. I've been doing this talk for a long time, and a lot of these slides are created from questions that people ask me, which is why I love questions, because they really help me figure out what people are understanding from what I'm saying. And one of the questions I would get most often, early on when I used to do this presentation, was, well, the United States is a really generous country. We throw open our arms to all of these immigrants from around the world. We bring them here, the tired, sick, huddled masses, and we give them all this opportunity, and it just takes them some time to essentially acculturate and become healthy and wealthy. And so you can't compare us to anybody else in the world. We're completely exceptional and unique. And if you just took all of the people of color out of the analysis, you would see that our health statistics are really great. And it's like, okay, let's do that. So this is US white life expectancy. The most recent data we have, it's about 79 years, which is pretty good. It's about that of Qatar, Costa Rica, and Nauru. Does anybody know where Nauru is? There's always somebody in the room who knows where Nauru is and has been there. It's in the Pacific Islands. Okay, so US life expectancy is actually shorter than Belgium, Chile, Denmark, Lebanon, Slovenia, Austria, Finland, Germany, Greece, Ireland, Malta, Netherlands, Portugal, the UK, Canada, Cyprus, France, Iceland, Israel, South Korea, Luxembourg, Monaco, New Zealand, Norway, Sweden, Andorra, Australia, Italy, San Marino, Singapore, Spain, Switzerland, and Japan. 33 countries in the world have greater life expectancy than US whites. In 1990, there were only 17. So US white life expectancy, one standardized measure of health status, is rapidly falling down the world rankings, rapidly. And it's not just that. This is a report that came out from the Institute of Medicine recently, looking at US health compared to 17 peer countries. And for those of you who know the Institute of Medicine, it's a fairly august body that is essentially commissioned by Congress to study issues of significance to health and science. So they don't tend to engage in a lot of kind of exaggerated rhetoric. When they did this study, looking at the US compared to 17 peer countries, this was their lead finding. The panel was struck by the gravity of its findings. Struck by the gravity of its findings. I've served on IOM committees, and these are committees where we bring witnesses in sworn. They provide testimony. That testimony is captured. You have to balance it in a sort of a partisan fashion. It's very serious business. When they say they're struck by the gravity of their findings, they're basically saying, I'm translating for you, holy shizzle, this is bad. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. The US health disadvantage cannot be fully explained by health disparities that exist among people who are uninsured or poor. As important as these issues are, several studies are now suggesting that even advantaged Americans, those who are white, insured, college-educated, or upper income, are in worse health than individuals in other countries. Okay, another truth test for the good people of Kansas. How many of you are surprised by this? Okay, Kansas is full of liars. You did not know this. You did not know this. Who? Oh, okay, so I asked the question the wrong way. Okay. You didn't know it, but you're not surprised. Okay. Why are you not surprised? Some brave soul with a microphone or whatever, tell me why they're not surprised. Obesity rates. Okay, that's probably one factor. Anything else? Back there.
Okay, so for example, everybody wants to lose weight and get healthy. How do you do that? You exercise. You know, I mean, we all know how to make the changes to make our lives healthier. Do we want to do it? Not really.
And why would Americans be less inclined to want to do it than anybody else? Okay.
That has to do with philosophy more than I care to elucidate at this time.
So it's basically our fault. We're fat and lazy is what you're saying. Okay. Not sure I agree with that. Yes?
I think it has to do with the amount of resources we have. A lot of our food has changed over the years through evolution, and a lot of it's being filled with additives and artificial ingredients, whereas in these countries, they have more natural resources, and they use less additives and BHS, things like that, that increases the shelf life in their products, and they generally get their meat from farms and different things like that, whereas we do as much as we can to produce a product as fast and quickly as we can. So I think it's those different agents that are killing our people, especially when you take Caucasians, regardless if they have health insurance or not. It's the food that we're eating and the resources that we have available to us.
Okay, so bad food, we're fat and lazy. Other things?
Yeah, I have to wonder if it's associated with productivity. You know, the work week in the United States is significantly longer than a lot of the other countries that we're being compared to. I would like to know how many people in this room go home every night and catch up on email. You know, we work longer. Our leave policies are very different from many of these nations, and I think that we're working harder. We don't have the time, maybe, to go and hit that gym after work because we have to catch up on the emails. I've wondered for years if that's a contributing factor.
Okay, well that's an interesting idea. There's some other hands here. I have an idea too. All of these are ideas. Yeah.
I think it's our narrative. I think in the U.S. we believe we're better than everybody else. We're gooder. We're prettier.
We're number one, right?
Yeah, we're number one. And even if we are a little fat or we don't do our exercise, we're still okay. We're better than everybody.
Okay, so we're delusional.
Do you want more ideas, Dr. Iton?
Sure, I'll take a few more.
Hi. I think think the most important thing is your zip code. A doctor once told me the most important question he can ask a patient is, where do they live? What is their zip code? If you take a walk down the street even in one of these neighborhoods, do they have sidewalks? Do they have street lights? They don't feel safe to get out and go walk. There's so many vacant lots. They can't go to the park down the street because there isn't one, or they don't feel safe. I think it's all with their environment.
Okay, that's great. I mean, if we had more time, I'd ask you, why is that? But think about that. We can talk about that in a minute. All right, maybe one more.
I believe it's our unwillingness to fund those upstream drivers of health and our unwillingness to tackle problems with a solution timeline that extends beyond the next election cycle.
Okay. And there's a why question to follow that one, too. I think that that's really interesting. Well, there's some eager hands here, so let's do it.
One of the big root causes of inequity is mental health diagnoses, the 25-year lower life expectancy, and African Americans are more likely to get on psych meds that negatively affect them. They get higher doses of meds for the same clinical symptoms, and they have less cytochrome P450 enzymes in their liver that process those drugs, so the drugs are more likely to not even work. So that actually is linked to death.
Okay, before you give the microphone away, I just want to ask a follow-up question of that young lady there. Thank you for that. Let me ask you, the data I showed you about white life expectancy and how it's plummeting down the international comparisons, how do you harmonize that with your thesis?
African Americans are more likely to get long-term mental health diagnoses, things that are said to be severe.
No, I hear you.
Whereas whites get diagnoses that says you can recover.
Okay, so how does that explain white life expectancy plummeting?
I didn't hear that.
You didn't hear what I just said?
Yeah, I didn't hear that question.
Okay, so I showed some data earlier. I'm just trying to understand how that thesis fits into the data that I was showing you about U.S. white life expectancy being 33rd in the world, having been 17th in 1990, and continuing to plummet. I'm trying to understand the role of mental health. I'm not disagreeing with you. I'm just trying to understand your analysis.
Essentially, whites get better mental health care than minorities.
Okay, I'm not sure I follow that, but thank you.
Yes.
Thank you.
I think one of the issues that when we start comparing across countries, it's the whole movement around the world in terms of rethink primary care, the role of primary care and specialty care. And when you see, even though you show that whites have worse health outcomes here in the US than other countries, but we do know that access to health, the primary health care wrapped around prevention varies, and you can see a lot of that in terms of life expectancy, in my opinion. Okay. So I'm very excited to see how we're trying to rethink that in our county, here in Wyandotte County.
Yeah, I mean, that's an interesting idea. It's actually how I started my career, was pursuing access to primary care. The data actually doesn't support that. Access to health care and access to primary care is not correlated with longer life expectancy, surprisingly.
Not the current one, but if we start rethinking the primary care, then I think we're going to start seeing.
Okay, I think you might be onto something there. All right, let's move ahead here. I'm going to offer you an idea, a concept here. I think at the root of this, the U.S. health disadvantage is stress, chronic stress. Let me try to explain that to you. First of all, there are differences, and some of you may have seen this. I hope some of you have seen this. I hope many of you have seen this because it got a lot of press. This is looking at, again, white working class mortality across the United States, showing that there are some really interesting differences that are manifesting themselves today in our health data that many people would not have expected. Right now, for instance, the lifespan for uneducated white women is lower than that of uneducated black women. How many of you knew that? Good, so there's finally some truth telling around here. All right, so this is that data. It came out in 2012 in Health Affairs, and this is essentially education stratified across from low education, less than 12 years of education, all the way up to 16 years or more. The blue is 1990, the green is 2000, and the red is 2008. And this shocking finding occurred, which showed that for poorly educated white women in the United States, we're witnessing an unprecedented plummeting of life expectancy over a relatively short period of time. This is a little noticed finding in Health Affairs in 2012. It led to a blog on trying to understand climbing death rates amongst whites, looking at women of childbearing age. And then this happened. Has anybody heard of Angus Deaton and Ann Case? They're two married researchers at Princeton. They just won the Nobel Prize in economics for work that they did on mortality. And what they found was this finding. Now let me take you through this. This is looking at white mortality, 1999 to 2013. This is overall black mortality rates, declining, but still higher than white and Hispanic. This is Hispanic mortality rates, declining. These are white mortality rates, increasing. Now, when you stratify by education, these are whites with college education, declining. Whites with some college, pretty much flat. Whites with no college, climbing. And climbing in a way that really is unprecedented. It's not been seen before. This has led to an enormous amount of attention in the press. Let me just check. How many of you have heard of this? Okay, good. All right, good. Then you won't be as shocked when I show you this next thing. So this is an analysis that was done in the Washington Post, which I thought was really interesting, looking at 9 states. And what they did is they correlated essentially poverty, which is on the bottom axis. So as you move right, you're going to poorer places, and the percentage of Trump votes in those states. And they found this positive correlation in multiple states. Does that say Arkansas or Alabama? What does that say? I can't read that. Arkansas, Georgia. You see this high correlation between high white mortality and high Trump voting percentage. I'm just throwing this out to you because I think this is significant. I think this is a real phenomenon, that there's some real pain happening in rural white America, and it's manifesting itself in mortality. Okay, so at the California Endowment, we spend a lot of time trying to illuminate this issue, shouting it from the mountaintops. These are our split screen images of real zip codes, real life expectancies. These are real zip codes and real high school graduation rates. We built a new terminal at the Sacramento airport. Sacramento is our capital. We decided we wanted to educate our legislators about this, so we put this up right in the terminal. I know that they were seeing it because I would get calls asking why I was decreasing property values in their districts. This was the American Public Health Association meeting in San Francisco a few years ago, where we literally festooned the building with these images. This is the governor's office in California, where he was nice enough to let us do this for a few months, put a big poster right outside his office. Don't know why he let us do that. All right, let's see, how am I doing here? There we go. Okay, so anybody who studied this long enough knows that the data is overwhelming, that healthcare has very little to do with health status. You can't predict anything in terms of population health status based on access to healthcare, even access to primary care. It does not correlate. 80% of what influences population health happens outside the doctor's office. And this has been known for a long time, and it's replicable in every country in the world. In 1993, there was this big seminal study, which was considered radical in public health at the time, which said that we should stop talking about causes of death. We should start talking about the actual causes of death. Don't talk about diseases. Talk about what's underlying the diseases. And they said there are only 4 things: the environment, access to healthcare, biology, and so-called lifestyle. That was 1993. It was radical. It was groundbreaking. Since that time, we've realized that even this is wrong. You can't actually draw hard and fast barriers between the environment and biology, because there's this thing called epigenetics, which is basically that, let me make it simple. If you take 2 identical twins with the same genes, and you put them into radically different environments, their genes will express themselves differently. They will have different genetic expression based on the environments in which they live. So this notion of nature versus nurture is actually a false dichotomy. Nature influences nurture, nurture influences nature. But that's not the most radical aspect of this. It's really, what does the environment do to our behaviors? We acted in 1993 as if behaviors occurred in a vacuum, as if people were choosing not to eat healthy food because they decided I looked at the healthy food and it didn't look good, so I took the unhealthy food. We choose to smoke because smoking feels cool or whatever, and I want to be cool. But we didn't think at all about how the environment shaped those decisions. And now we know there's a lot of data that suggests that the environment has a radical impact on those decisions, and it happens through this chronic stress pathway. The fancy word for it is allostatic load. And I'll skip this. Allostatic load is basically about stress. It's about stressors in our lives, and we all have stressors. Everybody in this room has stressors in your lives. What's different, perhaps, are the resources that you have to cope with those stressors. So we are stressed by long commutes, stuck in traffic, expensive housing, maybe being socially isolated or lacking friends and feeling like you don't have a community. Racism is a stressor, feeling like you're excluded, like you don't belong, like you're less than. Being exposed to crime, poor jobs, lack of access to core amenities like grocery stores or things that you need. And then so-called high-demand, low-control jobs, where you're basically like producing widgets and somebody is cracking the whip. Many people in public health actually complain of this. So what happens when you see a stressor? A stressor is perceived by the brain through the hypothalamus, which sends a signal to the pituitary gland, which sends a signal to the adrenal glands, which sit right next to your kidneys, and that releases a cascade of hormones, amongst which is cortisol. Cortisol has a variety of different findings. Boy, that color has really gone wild. In the acute, this is supposed to be actually blue. In the acute stress period, when you're standing on the street and a bus blasts its horn and it's bearing down on you, you want cortisol circulating through your body because it stimulates your cardiac output, it rallies glucose for your muscles to be able to run, it enhances your immune functions, turns down inflammation, and it stimulates growth of neurons in your hippocampus and prefrontal cortex, and those are parts of your brain that are really important for so-called executive function. Executive function is really being able to choose from a variety of options, some short-term, some intermediate-term, some long-term. And you need that when you're stressed. You want clear thinking. But cortisol in the long term actually has almost the exact opposite effect. It stimulates hypertension and cardiovascular disease independent of your behavior. Even if you don't smoke and you exercise and you eat well, you will see long-term cortisol stimulating hypertension and cardiovascular disease. It causes insulin resistance and glucose intolerance. It turns on inflammation, turns down your immune system, and it causes atrophy and cell death of those same neurons that are responsible for executive function. So imagine that we have an experiment now where you put somebody in a stress incubator, let's call it East Baltimore, for years, and cortisol is circulating regularly in their body. What you're seeing in those populations is chronic disease manifesting itself independent of their choices. Both diabetes and prediabetes, infections and multiple inflammatory conditions, and some decision making that you might say, well, why are you doing that? Why are you making these very short-term decisions? Aren't you thinking about the future? Stress over time changes our physiology. Wealthy people and poor people are actually physiologically different. They weren't born that way. They become that way because of the environments in which they live. I'm going to skip this. I'll just reference it quickly. There's oftentimes some nerds in the room who really like to understand how this actually manifests itself down at the cellular and genetic level. The way that chronic stress manifests itself at the genetic level is through the lengthening and shortening of these things called telomeres. Telomeres are like the caps on the end of your shoelaces. They control how long a cell lives. And short telomeres are stimulated by they're associated with a whole range of diseases, including age-related diseases, cancer, stroke, vascular dementia, cardiovascular disease, et cetera. This is what they look like, those little blue caps on the end of chromosomes.
Dr. Iton, we have a question about the telomeres.
Yeah, great.
Sorry, not about the telomeres, but just about the stress issues that you're discussing. There's been a lot of news lately about the lack of sleep that people have and how important sleep is and how stress influences your sleep, lifestyle, a lot of things like Kathy mentioned as far as work. And what are your thoughts about that, about our culture's lack of sleep and your body's ability and your immune system ability to recover?
Yeah, so sleep and stress are associated. Acute stress, at least in the research literature, is more associated with insomnia and sleep disorders than is chronic stress, which is not to say that they're not associated, it just hasn't been studied and a correlation hasn't been shown. But on acute stress, yes, sleep disorders are very associated with acute stress. Okay, so we know now that telomere length is actually reduced by poverty, education, so-called safety stress, that sort of fear of crime and feeling insecure, negative social interactions, low neighborhood satisfaction, hopelessness, and obesity. So I want to stop for a second here, because I want to, in some ways, summarize, although I'm not done, much to the chagrin, I'm sure, of some people. And I want to talk about what we know now. And the greatest frustration for me, and I think many other people who work in this field, is we have what we know and what we do. And it seems that given what we know, what we're doing is woefully inadequate and possibly bereft of critical thinking. What we do for $3 trillion a year is that we treat individuals with remedial health care, and we offer them brochures and pamphlets about how to change their behaviors. I'm not saying that that's wrong. What I'm saying is it's not sufficient. What we know is that there are environments that incubate stress. And those environments are man-made. And I often like to say they will be unmade by the work of women. Sorry, guys, we make messes. We need a practice that helps ameliorate those conditions. And that practice has to be informed by what we know. So the biggest failure, I think, of our society is not engaging our critical thinking about tying what we know to what we do. So I want to show you a little bit of a video that we're trying to create to help people sort of understand how these things are tied together. It's about 3.5 minutes. It's still in a slightly raw form, but I'm using you as a test audience for it.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs, they're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in B-Ville, around 4 miles away. They're similar in so many ways, but here's the thing. On average, residents of B-Ville will die 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb's and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher. And there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventative health care. On the other hand, Beeville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhaust from the nearby highway. And for food options, Maria's only choices are Beeville's many liquor stores, fast food places, or convenience stores. The schools in Beeville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, not having the same healthy options as A-Town can be overwhelming, a constant source of stress and a health issue. In fact, for all the residents of Beeville, it drives health problems like obesity, diabetes, asthma, and heart disease. And how did A-Town and Beeville get so different? Well, in many cases in cities and towns across California, it began with racial discrimination. Over the generations, poor people and people of color were pushed to less desirable parts of town. In those neighborhoods, banks refused to lend money. Businesses left, jobs too. Schools declined, and the neighborhood crumbled. Everyone who could move away did. And here's the thing, when communities like A-Town and Beeville are so unequal, Beeville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you'll live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, or upper income, die younger than their peers in other countries. In fact, our life expectancy is 42nd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality. Inequality hurts us all. So what do? Well, if we're all going to be healthier, we don't just need to help the folks in Beeville beat the odds. We need to change the odds for everyone. And that's what we're doing. There's a movement happening. We're Californians. We don't follow, we lead. We are making health happen in communities across the state. We are coming together to build one California. A smarter, healthier, and more equitable state that creates opportunity for all of us. Join us. To learn more, visit calendow.org/buildinghealthycommunities.
Thank you. Okay, so now I'm going to just take you through a quick framework, and at the end we can talk about the video and any other questions that you have, which helps just explain where the opportunities are to change our practice, to intervene. There's a group in the San Francisco Bay Area called BARHI. It's the Bay Area Regional Health Inequity Initiative. And it came together basically out of frustration. It was 13 public health departments that were frustrated with the tools we had at our disposal and the challenges that we were facing in public health. We recognized that our tools were inadequate to the challenge, and so we wanted to develop new tools. Part of developing new tools is understanding sort of how we use our existing tools. And so we developed this framework, which is the medical model, which basically says when you look at premature death, short life expectancies, they're driven by higher burdens of disease and injury, which is driven by risk behaviors, and risk factors. And the basic tools we have at our disposal are tinkering with people's genes, trying to improve healthcare access, and trying to change what people know. And that's pretty much what we spend $3 trillion a year on. And we argue that all of this is necessary but not sufficient. There are other opportunities upstream in the socio-ecological domain. The medical model really focuses on individuals coming through kind of a pipeline of healthcare. The socio-ecological model focuses on communities. And what we recognize is that we have social inequities that manifest themselves oftentimes in places like East Baltimore or Kansas City, Kansas, or Wyandotte County that are driven by policies, the behavior of institutions, corporations, government, other businesses that essentially create policy that disadvantages people in certain places. And it's not just geographically concentrated places. You have populations of immigrants, LGBTQ, formerly incarcerated people who don't all necessarily live in a place, but they're similarly impacted by policies and practices that disadvantage them and skew resources away from them. And why is this? Well, we think that there's a narrative in this country. It's not the only narrative, but it has been a dominant narrative. That is a narrative of isms. It's about who belongs, who doesn't belong. And it's about who we are. And that narrative basically says that certain people are not deserving of resources, and therefore our policies should essentially create for them barriers to opportunity. And so in this model, we think of health disparities as living downstream in the medical model, health inequities living upstream. You can take the word health out of the equation and just talk about inequities producing disparities. Or if you're simple-minded like me, you talk about conditions producing consequences. And we spend more than enough money on consequence management, or as I like to say, damage control. And you can actually think of these downstream consequences not just as health consequences. You can see them in the educational system. You can see them in employment. You can see them in housing. The point is that we spend a lot of resources, as that Elizabeth Bradley graphic I showed you, where we have the accent on the wrong syllable. We spend a lot of resources in this downstream effort to essentially bail out disasters that we created by not focusing upstream. So what we're arguing is that while we have a downstream practice, and it's important, don't get me wrong, I'm a physician, I'm an internist. I believe what I do is important, taking care of people who are ill. And I say to people, if you walk into a community and you see fires burning, what's the first thing you do? You pick up a hose and you put out the fires. And then if you're in a Budweiser commercial, you high-five your buddy, you go to a local bar, you drink a couple Budweisers, and you say, aren't we great? And then you get up the next day and you go back to the community and there are fires burning in exactly the same places. So now what are you doing? You pick up a hose again and you're putting out the fires. But maybe this time you're not going to the bar. Maybe you're thinking, that was weird. Why are there fires in exactly the same places? Next day you get up, you come out of your house early because you're curious, you look out and there's fires burning in exactly the same places. You're like, okay. As you're picking up the hose, you're asking yourself, what the hell is causing these fires? How can I prevent these fires? And that's what the rest of this work is about, is how can we prevent these fires? And we argue, we're trying to simplify it for people to develop a practice that you have to look at place. You have to look at the conditions in which people live, those environments, the social environment, the physical environment, the services environment, the economic environment. How are those environments conducive to healthy opportunity or disruptive of healthy opportunity? That's not sufficient. You also have to look at the policies that create those conditions, or oftentimes the absence of policy in the face of abject need. When you have high school graduation rates that are 30, 40%, that's not a high school. That's actually not doing what the school was supposed to do. You need to change that. But oftentimes we shrug our shoulders and we say, we're doing the best we can. We also think that there's a narrative that creates that policy about who matters, who belongs, who's in, who's out. And if you want to change the policies, and this is something that progressive-minded people are really bad at, we go immediately to policy and we don't recognize how narrative controls policy. And one of the things that conservatives do very well, and I have a great deal of respect for them because they understand this, is that they go immediately to narrative. They talk about who we are as Americans, who matters, who's important. They separate us from them. I'm not saying I agree with their argument, but they set up their argument around narrative, around values. And that's where people live. People live in their values. They don't live in their heads in policy, detailed, prescriptions for change. And progressives need to get better at talking about values. We also think, sorry, did somebody say something? We also think that it's critically important to enlist the participation of people that are experiencing the inequity in the reshaping of policy. This is about the power arc. Building social, political, and economic power and a critical mass of people living and experiencing the inequity is the only route to solutions. You can't prescribe this kind of change. You have to invest in it. You have to pay community organizers to build this power, to change those systems and to hold them accountable. And for too long, We've been saying that we can sprinkle pixie dust on these places and try to make them change. You know, build some new housing, you know, throw in a grocery store, maybe put a few trees up and, you know, put a grassy median on the boulevard, and we're like, I don't understand, why are they still unhealthy? You have to enlist the participation of people who are experiencing those conditions. And it's no longer just low-income people in this country. We're talking about middle-income people. We're talking about all of us. Our politics is broken. Okay, so very simply, the medical model says bad behavior produces disease, which produces death. The socio-ecological model says that bad societal behavior, or isms, produce policies and practices that create communities that are on life support. We have interventions to try to prevent death. We call them emergency rooms. We have interventions to try to manage disease. We call that clinical care. We have interventions to try to change behavior. We call that health education. All of that is important and necessary, but it's not sufficient. We don't really have interventions to address communities that are on life support. In our practice, what we see is most important is building power and leadership. We think that that's insufficient, though. You also have to look at the policy and practices and build partnerships across silos, across disciplines, across sectors to address these convoluted, sometimes referred to as wicked problems. Even that is not sufficient. You have to change the narrative. You have to do all of these things, we think, to actually intervene upstream to create conditions that don't create these adverse and inevitable consequences. So we've simplified this practice into what we call the drivers of change, and we can talk about that later. Let me talk very quickly about what I do for a living. Now, I'm a very lucky person, like Billy. We get to work in these privileged positions where we have a $3.7 billion bank account, and we spend roughly 5% of that, sometimes a little bit more, every year in California with an explicit mission to improve the health status of Californians. And so I got hired because our board decided they wanted to do something different. After its first 10 years of existence, it's now 20 years this year, they wanted to do something different. They wanted to do something long-term, deeply invested, that would move the needle on some critical health measures, particularly for low-income people. So they said, hey, will you come here, and here's the deal. You have $1 billion, 10 years, 14 low-income places that are experiencing health disparities. We want you to measurably improve the health status of these populations over that decade, with one caveat. You cannot spend a nickel on health care. And that's my job, is trying to figure out how to improve health status in populations without going through health care. And so that's what we do. We created Building Healthy Communities, where we recognize that health happens in communities. It doesn't happen in the doctor's office. We ask ourselves about these kinds of communities. Who built this? Why was it built? Why is it allowed to persist in this way? We ask ourselves about the social contract in this environment, the physical, social, economic, the services environment, the political environment. How can we actually enhance those environments in a way that's health protective and reduce the risks in that environment that are detrimental to health? Our theory of change is that if you want to change health status, you've got to change the environment. If you want to change the environment, it takes a while for the environmental change to become health status change. But if you want to change the environment, you've got to change the policies and systems that create that environment. If you want to change the policy and systems, you have to build power. That's our basic thesis. And this is the pretty version of that. These are the 14 places. For those of you who don't know California, this doesn't mean very much to you, but this is our Central Valley. So we have a number of places in the Central Valley. This is our northernmost county with multiple Native American reservations up there. This is our Bay Area, this is our Central Coast, and then this is the LA area and San Diego. We're spread throughout all the population centers in California. The backdrop to all this work is a raging debate about income inequality, mass incarceration, Black Lives Matter, the Syrian refugee crisis. All of these things are sort of setting the backdrop for our work. And we recognize that you can't do this work divorced from these larger social phenomena. We have to understand what's driving opportunity in this country. One of the common themes in these efforts is this notion of shifting the paradigm from one of exclusion, us versus them, to one of inclusion, where we're all in this together. Human capital is by far the greatest resource. I have $1 billion, which is not a lot of money in California with 40 million people. This is our greatest resource, the people that live in these communities. Our goal is not to help people beat the odds. Our goal is to try to change the odds. Some people are dealt a very unhealthy hand. So what does our work look like? We spend a lot of time with communities, helping set the agenda with the community. We've organized the environment into 3 campaigns, looking at schools, looking at neighborhoods, and looking at prevention, which is really the health system and social services system, the criminal justice system, those systems that have a lot of impact on low-income people and their families. We have these 12 policy domains that we're working on. By the way, you can all have these slides, so you don't have to try to write anything down. We think that this is basically the menu for a healthy community, if you can get good policies in each of these domains. How are we doing this work? We're focusing on key systems, as I mentioned, health systems, the human service systems, the schools, and the land use systems. And in the middle of this, and I think this is, it doesn't sound innovative, but this is the most important thing, is you got to bring the butcher, the baker, the candlestick maker together to make a meal. And you got to do this over time. They have to have the ability to form human relationships. And too often we don't give them the time, we don't give them the opportunity. We're setting a table for a decade in a community that is funded, there's food, there's childcare, there's transportation, there's translation services, there's transcription. People just have to show up and work outside of their disciplines with other disciplines to solve root cause problems. And they love doing this. This is a unique opportunity. Collaboration is hard. What we can do, and Billy and myself and others in these positions, we can do our best to facilitate these conversations over time with a clear agenda that is set by the community. So this is the secret sauce, resident power, organizing. We have to create social, political, and economic power and a critical mass of people living in these communities. And critical mass, by the way, may be 1% of the population in these communities. Build that power. We have to foster this collaboration across various disciplines. We have to empower youth. Somebody reminded me the other day that the average age of the people crossing the Edmund Pettus Bridge with Martin Luther King was something like 28 years old. Young people make change. Sorry, old people, I'm one of them. We can facilitate it, but the young people will drive it. And we've recognized that this is critical to our work. You have to leverage private capital. We're now building grocery stores in our low-income food deserts throughout California. We put $30 million into a fund, raised $300 million in 18 months, money from Bank of America, Citibank. That fund is exclusively dedicated to building grocery stores in low-income food deserts. And you have to change the narrative. We think that's the recipe for building healthy communities. I'm going to stop here just by summarizing that it's about power, it's about policy, and it's about narrative. I will skip this case study. So I'd love at this time to get, and I know this is not very Kansas-like, I would like to get rude and insistent questions. Those are the best ones. The ones that say, you know what, dude, you're wrong. Because that's how I learn. And I'll take polite ones too, by the way. Polite, friendly questions, observations, insights. There's bright lights shining at me, so I think there's a hand there.
So
where are we? Oh, there we are. Somebody's got the mic.
So thank you for your presentation. So I'm not from the States, I'm from Haiti, where lots of NGOs are trying to improve access to primary care or health care, what Heart to Heart International, the NGO I'm working for, is doing there, and they are making a really good job. But something that I learned this morning is something that I was complaining about. I was complaining about like the problem to access to healthcare in my country when I was like shocked when the country director for Heart to Heart International told me that we have the same problems in Kansas City, and they are trying to provide access to primary health care like in Mississippi Valley, where they have people with almost the same problem we have in Haiti. And this morning I was reading an article about Haiti where like only 5% of the budget, of the national budget, is invested in health. And what I learned here, it is not a bad thing if the rest could be invested in like social services, because as you said it, the more you spend in social services, the better your health is. So it is something that I think that I need to spread, to tell people, and to improve healthcare. So Heart to Heart is learning how to do it, because when we went to Haiti trying to provide primary healthcare to people, we were just coming to give primary healthcare. But when we see the population is not educated there, so we are now trying to improve the capacity of those communities for them to take responsibilities. It is why I am here, like, because they are trying to improve Haitian leaders to take care of themselves and improve those communities and to have better quality of life, better healthcare. So I think if I learned something today, what I learned is that we must invest in social services to improve life, to improve healthcare. Thank you.
Yes, and let me just put a little caveat on that. In social services, at least the study that Elizabeth Bradley and her colleague did, what they call social services is a mix of services, but it's really social benefits. It's really the kind of things that I was describing that happen in Canada: universal health care, universal dental care, universal child care, education subsidies for K through 12 and post-secondary. These are benefits in society: unemployment insurance, disability insurance, that anticipate risk and try to head it off before it occurs. Social services are typically waiting for people to crash and then trying to service them back to some state of normalcy. That's important and necessary, but it's really social benefits, it's the social contract that's most important, because it gives people a sense of being valued, like they belong. And that, to me, is the most health protective intervention that we can make.
So along those lines, I'm glad you said that. Along those lines, I think one of the challenges we have is as we empower people that we don't do a dump and run, because honestly, it does take money to change these things. And we do have funds available, but we never put our funds where our talk is. It takes us a little while to catch up with that phenomenon, and so it keeps that we-they dichotomy in place. Sometimes when my experience has been, when we empower communities, we can't really show that what they've shared with us was actually used in that process. So sometimes it's like, well, come to the table and tell me what you think, and then when it's all wrapped up and put in this package, and you open it, it's like, well, here's what we're gonna do. And so it's still a patriarchal kind of intervention. And if we wanna move the communities, we have to move past that, even as leaders and planners. So you're not wrong. It's not a wrong. It's in addition to what you're sharing. We need to do those things as well.
I will accept that. Thank you.
Oh, okay, I'm up. First of all, my name is Richard Mabey, and I'm president of NAACP here in Kansas City, Kansas. And I was invited to the meeting. I really wasn't for sure once I sit here because of the data aspect that you were dealing with. That's far from us. When I say us, I'm talking about us grass level greening of America folks. Even though I do know there's a way for us to join it together, but I think it ended up being God sent, because by the end of it, luckily Ursula was sitting here, because I got to the point of trying to figure out what all this was about. And I see it's a phase that we're going to have to start blending together to get an understanding with the people that y'all creating these data gathering vehicles for, because our responsibility is to make them explain what it's about. Because as I see it right now, people are giving you answers because they think that's what they're supposed to do. And I'm not for sure if you're getting the right answers or not, based on the fact that we haven't had a chance to really educate our public about the fact that why these data sheets are necessary. The other issue I got is that the majority of the folks that's running these programs are white. And my concern with that is even here in Kansas City, when I come to programs, I'll walk in sometimes, and if I hadn't found out about it from some other situation, there would have been no one black sitting in that room making decisions about health care in the inner city. So I just want to get those two things on the table.
Yeah, no, I appreciate that. Thank you very much. You know, in our work in California, we found that our communities understand this better than our health providers. You know, I've done this hundreds of times. I did this at San Quentin Prison. And the most deep connection with this work are people who are living it, people who experience it. They're kind of like, of course, that's what's happening. And it's really the fancy educated people with a lot of degrees behind their name like me who don't get this, because we're trained to essentially separate people from their environments and treat them as if they're these units of physiology that we need to alter with chemicals. And so this is really designed for people who don't live in communities and don't experience this every day, because people who live in these communities where they're experiencing this every day get this. They totally get this. I think that one of the things that happens a lot in this work is that people conflate health and health care. And they think that they're the same thing, and they are not the same thing at all. And that's what this is basically about. It's about, if you're really interested in health, you have to go spend time with communities and let communities set the agenda. Otherwise, you're not talking about health. If you're interested in health care, I don't know why you would be, because it's not like it really is generating much health. But if you're interested in health care, you know, go into the emergency rooms or the clinical space and be the expert, providing you know, your exalted wisdom to the masses. I don't personally think that that's terribly effective in actually improving health, but that is what we do largely.
I have a question, Doctor. First of all, I'm not a data guy, but I get it. This is fascinating for all these really smart people in this room. So my question is there a way to pull out of your presentation no more than 6 slides that as a city manager I can take on the road? Because when I go out to community groups, I need to be able to help community people understand it's not just about health. That's a component. It's not just about education. It's a component. And you have to be able to say to community folk, it's about all of these things, and where the hell am I going to start, and what the heck am I going to do about it? Mm-hmm. I need about 6 or 8 slides that help me get there.
Yeah,
Please.
First of all, you're welcome to all of these slides. You can pull out your favorite 6. But so I think the big points, the big takeaways, this is just experience. Depending on who your audience is, I spend a lot of time talking to media and policymakers. And then the other half of my job is working with community. And media and policymakers need things like these maps. They need to see that their district has a problem. And they need to see that compared to other places, their problem may be worse. They have to be put in the hot seat. They have to be held accountable. Media love things like this because the readership understands it. They can sort of say, I live there. Oh my God, what's happening in my neighborhood? So that's really critical. The second big piece, I think, that's important in this work is this notion of chronic stress. Because, you know, when I asked, you know, what's causing this, we had a litany of causes, and they're all right. What's common about them is essentially the pathways through which they operate on human health. And that is to create this sense of stress and this sense of not belonging, being shut out from opportunity. And if we can create for people, and the best way I know to actually change people's sense of control over what happens to them is to organize them. And when I say organize them, it's really them organizing themselves. Because it's the ability of people to see themselves as having some value in helping somebody else, and seeing their collective ability to essentially control some of the circumstances that are happening to them in their lives. And that's really critical. So I oftentimes refer to this work as optimizing democracy. It's really enlisting people to participate in kind of like a much more robust form of democracy that's local, that's relevant to their daily lives. So I think that that's the second and third piece. So the maps, chronic stress, and this notion of control. When you get confused and you think, is it education, is it housing, is it transportation, it's all of those things. It's about how people essentially navigate opportunity in their communities and what kind of control they have over this. And then, you can select from, what your other 6 or 8 slides are from the rest of this. I think the cost stuff works for some people. Some people are shocked at how much we spend and how little we get for it. I think it's important to shatter people's myths about essentially the health of white people, which is what we use to compare everybody's health to. Actually, if we wanted to have a high standard of health, at least in California, the longest living, healthiest population in California is low-income Latino immigrants. We should compare our health to low-income Latino immigrants. And immigrants in general have better health than native-born Americans. And as immigrants acculturate, their health gets worse. America is not good for your health. So these are things that, shatter people's myths about what's happening. Showing that we're, 43rd in the world in life expectancy and dropping. That helps people, disabuse themselves of some of the mythology about who we are and what we're doing to ourselves.
Well, first, thank you. This was just amazing and thought-provoking, and love all the data.
You have to put the mic closer to you.
Oh, sorry. Love the data, and I'm left with a million questions and thoughts, but I'll keep it brief. And in terms, what it makes me think about, in terms of policy, you've probably heard people say, what's the plural of anecdote? Policy, and
right.
That's what happens. And so I'm just thinking about in my world where I'm working with policy a lot and watching how health policy has changed, trying to think about how we can help change the narrative. Because for example, in some work that I do, trying to improve access to certain care, we all know policymakers don't want to pay for anything now that will save money later. It's just a non-starter. And how do we make them care about people that are marginalized? And just like we're talking about, people with chronic conditions, mental health, substance abuse, all diseases are marginalized. And how you mentioned some people just aren't deserving is how it seems. So trying to kind of break through that narrative. I've seen some of the stats that you shared about how horrible we spend more on healthcare and get so little. And I always think our nation is so competitive. How can we use some of this data to show in talking with strategists around policy? I've tried to go that angle to do infographics, and they say you have to make it very real and specific. You can't just talk in these generalities, but you have to show them and show them how, perhaps how people are doing better being treated with a disease in a different country compared to ours. And you may be able to highlight in some countries it's, the home health services that are free, and so chronic conditions are dealt with horribly here. So I think I'm obviously saying a lot of words, but I think my question to you is, how can we change the narrative with some of this data to help change, get people to care about these things differently and show them and get our policies to change? And I can say more if you have questions about what I'm trying to ask.
Yeah, no, I hear your frustration, actually, because I hear it a lot, and I think it's real. And I don't want to imply that this work is easy. It is not. I think it's necessary, but it's not easy. If it was easy, we probably would have done it. And I think it's probably harder in places like Kansas, where your politics are really kind of deeply imbued with this narrative of personal responsibility and individual choice, and government is bad, and and liberty, and that's part of this sort of narrative, which basically also others people. So I think the narrative work is critical in places like Kansas, and you have to speak to shared values that people understand. One of the reasons I emphasize the maps with policymakers is I've seen this. If you sit down with them and say, this is your district, and the media knows this too. They're calling your office saying, your district has the highest obesity and diabetes level in the state or in the county or whatever. What are you doing about it? So that's a form of holding somebody accountable for these results. And then the power piece, policymakers may say, I don't care about those people, they don't vote. I don't care about those people, they don't have a lot of power. That's why we build power. Because we want to make them care about it or essentially be pushed out of office. Those are the only two things I know that policymakers respond to, is being shamed or embarrassed and being threatened. And I mean that in the best sense of both of those words. And we have to remember that they are representatives. Their goal, ostensibly, is to represent their community. That means their community has a role, too, to remind them of what they need to have represented. And I don't think Kansas is much different from many parts of California or anywhere else where we don't have a lot of political participation. People don't necessarily spend a lot of time engaging legislators and policymakers around these issues. They may yell at them at a town hall, but they're not engaging them in a constructive dialogue about policies and strategies, and that's part of what we do. We're investing more in community organizing in California than in anything else, because we actually believe in democracy, and we think that health is dependent on democracy. So that's the best answer I can give you. I can also tell you I've seen it work. As a matter of fact, I have never seen it not work if you do it right.
Hi, my name is Sherry Hall. I am a poet and also an activist. I work with a lot of different people. And you have presented some very interesting research here. I am a sociological person as well. So looking at all the numbers, the first thing I think of is the extraneous variables all the time. That's the first thing I think of. That's neither here nor there. That has nothing to do with my question. We're talking about changing the narrative. And I would like to urge you to include more into the narrative. Being an artist, I have found that in a lot of the more impoverished and poorer communities, we have less arts programs. And I am not just only speaking for children, I am also speaking for adults. But if we're going to speak about children in our schools, the music programs are getting taken out, the art programs are taken out, and a lot of times community organizations are coming in and filling those voids, but they don't have funding, which means you're asking these adults to come in and teach babies for free so they can stay impoverished with them. We have to change the narrative on that, because art helps relieve stress in a variety of ways. I'm actually from the Missouri side, and I can tell you east of Troost, there are no arts venues outside of the 18th and Vine Jazz District, which is one block. So we have one block. However, west of Troost, we have theaters, galleries, cultural houses, XYZ, all kinds of different things west of Troost. East of Troost, you will find there is nothing. And that goes to say the people there, again, do not feel included. We don't have a part in this conversation. We aren't seen as creative minds. And if you're not seen as a creative mind, even if you get invited to the table, what creativity are you going to bring to the table in terms of policy making changes and things of that nature? So I would encourage you to include arts into the narrative.
Yeah, no, thank you very much. I appreciate that. And when we talk about changing the narrative, we're talking basically about two things. We're trying to change who does the speaking and what they say. Billy and I were at GIH recently, and we hosted a plenary where we brought up one of our grantees. It's called Youth Speaks. and they do spoken word. And that's their way of engaging in this narrative process in our communities in Oakland and Los Angeles and Fresno. So we create these competitions where young people can come and tell their truth about what they're experiencing around diabetes, around obesity, around guns, around a whole host of things. And so we think that narrative change is not just what we say, it's who does the talking, who speaks for these communities. And we find that this is the most powerful way of reshaping the narrative. In California, we have a big issue with undocumented people, and we've changed the narrative about undocumented people. When I say we, I mean a lot of us working together, using undocumented people as the spokespersons for policy change. In California, we have undocumented people getting driver's licenses, undocumented people getting in-state tuition for college, undocumented people getting access to state-funded scholarships, undocumented people getting access to Medicaid in California, state-funded Medicaid for young people. Many of our counties provide health services for undocumented populations as a result of advocacy by these populations that we have facilitated. And many of our young people use arts and culture as their mode of expression. And so our Building Healthy Communities effort is deeply steeped in arts and culture, particularly for young people, because that's how they feel like they belong. That's how they communicate. That's how they express themselves, not through fancy medical speak about allostatic load and all kinds of things like that. So I'm with you, sister. I mean, that is really critical to this work.
Dr. Iton, Pamela King Burns from Wichita, Kansas, Sedgwick County Health Department, and I have been sharing natural causes for years with pastors and with medical students, and now have an opportunity with pharmacy students. Because I do work for local government, the people I most desire to share this social determinants of health and this ecological conversation with are policymakers. I agree with my sister. And when you say you're changing the narrative, by proxy, we're going to be changing policy and then changing, the rest of it, right? So I go back, I said all that to say that there is an elephant in this room, a couple of them, but I just am going to address the one, is that the higher up we are ecologically and socioeconomically and all of those type things, the less we care. Do you see what I'm saying? And until we begin to care about one another, these issues are going to persist. And until we are able to establish the type of relationship between community and policymakers, the same thing is going to happen next year and the next year and with 20 years down the road, upstream, downstream, whatever. If we don't like each other, we're not going to work with one another. That's the other elephant. And we're very polite here in Kansas, sir.
So I've noticed.
I'm not that polite. I was born in Oklahoma.
That explains it.
I claim Kansas, but let's tell the truth about some things. Resources, people are fighting over those because we tend to think of them as limited. Right. And so we have the what's in it for me attitude and this is mine and they're taking all of mine. And until we as practitioners and policymakers and leaders and change leaders in our community begin to speak, and again say openly and honestly about things that impact us and realize that we are in a relationship, then we are going to continue with this. So I'm going to stop there because I'm also a preacher, but she made a mistake and gave me the microphone. And but I want to tell you thank you for coming. I will be eagerly searching the internet for more tools to use to go out and engage the community. But I think we should, as a group here, contract with one another to be creative, to be mutually adaptive, and let's just go to the hard places and have some hard conversations so that we can affect change. And thank you so much for coming to Kansas.
Yeah, thank you. So I want to say just a couple things to that. One, you people in Kansas ask really long questions, so that's another thing I know about Kansans now, and maybe Oklahoma influenced Kansans. Two, that one of the biggest myths in this society, and it's huge, I mean, it's huge, and I quite frankly don't understand it, is this notion of scarcity. Like where somehow we don't have enough resources to do this right. In the US, like we're too poor to figure out how to essentially invest in education or early childhood. And that's the myth of scarcity. We live in a land of great abundance, of excess, in fact. And this notion that somehow, you know, once you get yours, you've got to protect it, you know, fiercely against the hordes that are trying to take it away from you, is really it's influenced by that narrative, the narrative of who belongs and who can participate. And we have to get past, we have to stop talking about scarcity, that there's not enough. There's more than enough. But there's a benefit to all of us essentially looking at how we use our resources. This is really a fundamental question for us, is do we want to actually improve not only other people's well-being, but our own, through looking at how we use our resources. Now, the last thing I'll say about this notion of caring is I find that people do care. I find if you speak to them in the right way, if you speak to their values, their shared values, people care. You know, like I said, I spend a fair amount of time talking to formerly incarcerated people. And the question I often get from them is, how do we make, in Oakland, you've got flatlands and you've got the hills, and the wealthy people live in the hills and the poor people live in the flatlands. And the question I get often is, how do we make the people in the hills care about us? And so we started actually going to the hills and asking people, you know, what they thought about this work, how they wanted to participate in this work, and we got overwhelming response. People actually want to do something. They just never get asked, and they don't get asked in a way that actually comports with their values. And so I think that we shouldn't assume that people don't care. I think that we should spend the time to figure out how do we speak to them in a way that actually triggers their sense of collective responsibility about their community. And I'm very hopeful about that because I see that all the time. Thank you very much, Kansas, and thank you, Billy, for inviting me.
Yes, we feel very honored to have Dr. Iton with us, and thank you, all of you, for this really important conversation. I'm sorry we didn't get around to all the questions. If there's something that you'd like to share, we'll be here for a little bit. If you want to post anything on our Facebook or Twitter accounts about today, the conversation, about some of the information that you've learned, feel free to do that. We have put that information up there for you. We have videotaped Dr. Iton's presentation. We also will have the slides available, and that will be on our website as well, probably later today or tomorrow at the latest. Also take a look at the mural that Chris has developed. And again, thank you. We are very invested in working at the community level. We know we can do more and we can be better at what we do. So if you have some interest in what we're doing, please leave your business card or talk to me before you leave. A lot of you we're already connected with, but if we're not, we'd like to do that. So, okay, thank you, everyone. Thanks for being here.